Hello and welcome to another episode of Cracking Addiction with Philippe Naren and Fergal Armstrong. On the episode of Cracking Addiction today, we're going to be talking about MDMA, or 3,4-methylene dioxymethamphetamine, also commonly known as ecstasy or Molly. Now, MDMA is a sympathomimetic amphetamine that causes a release of endogenous catecholamines such as noradrenaline and dopamine, and that's how it takes its effects in the human body. It's had a wide range of both medical and recreational uses. In medicine, it has been used as an appetite suppressant in the early 1900s, and then from the 1970s and more recently, it's been used for its psychedelic effects and for its treatment of some conditions, in particular treatment-resistant PTSD. Now, MDMA is a pretty complicated drug, and it's also got some analogues such as para-methoxyamphetamine or PMA, as well as para-methoxymethamphetamine, PMMA. So Fergal, could you take us through some of the pharmacokinetics of MDMA, PMA and PMMA?
Sure. So I think it's important to understand that MDMA is merely the best known of the family of these substances. So in particular, if we look at PMA and PMMA, so they both are potent serotonin and noradrenaline reuptake inhibitors. So they both increase the synaptic concentration of these monoamines. They're also potent releasers of these monoamines. And gram for gram, they're more lethal than ecstasy. They cause more hyperthermia and they cause more serotonin syndrome. So given the hyperthermia and the serotonin syndrome, it's not surprising that they're also more lethal. If we look specifically at PMA, we can see that compared to ecstasy, it's got a delayed onset of action. So therefore, that actually increases the risk of fatal overdose, because you take the pill and you think nothing's happened. Therefore, you think you haven't taken enough. So therefore, you take some more. So you end up with a staggered overdose effect. And it also causes a large hypertensive effect, potentially a hypertensive crisis. So it can cause rises in blood pressure up to 60 millimeters of mercury, just very quickly like that. If you look at PMMA, again, it does cause tachycardia. It causes myochymia, which is that spasmodic eyelid contracting and like that. And it also causes compulsive yawning, and it tends to actually be devoid of any enjoyable subjective effects. So really, it should be regarded as a pollutant, because you're not getting any bang for your buck with PMMA. Overall, however, I think if you forget everything else, the difference between ecstasy and PMA and PMMA is you're at more risk of getting serotonin toxicity. Can you explain what serotonin toxicity is then, Philippe?
Sure. So serotonin toxicity is, as the name kind of implies, an elevated level of serotonin in the body's system. And the thing that we worry about is serotonin syndrome. And serotonin syndrome in this situation is when the effects of MDMA, PMA or PMMA cause elevated levels of serotonin, or it interacts with some of the other drugs that a patient may have taken and causes elevated levels of serotonin. And this can be dangerous because it can cause muscle spasm, elevated blood pressure, and it can cause a whole constellation of other symptoms such as rhabdomyolysis as well as hypothermia. And it can be, in serious cases, serotonin can be a life-threatening condition. So that's why we're so mindful of serotonin and why we are concerned about the risks of serotonin syndrome. But Fergal, I guess a question I was going to ask you was, I guess, the fascinating effects of MDMA in the sense that it's an atypical amphetamine-type substance, but it has a whole range of effects and interactions in the body. It's a stimulant, but it's far more than a stimulant, isn't it?
Yeah. So, yeah, it's well described as an atypical stimulant because it is a stimulant, because, all stimulants basically either increase noradrenaline or increase synaptic dopamine. So, it is a NET and DAT inhibitor. But it is also a SERT inhibitor, right? So effectively, it inhibits SERT more than it inhibits NET and DAT. So therefore, its predominant monoamine that it really has an effect on is serotonin. So it does increase synaptic serotonin preferentially. It also releases monoamines from presynaptic neurons. It also inhibits tryptophan hydroxylase. It also inhibits monoamine oxidase. So again, it inhibits the degradation of these monoamines. And also, it is a serotonin 2 receptor agonist. In particular, that means that it can have psychiatric effects. So overall, to summarize all of that, we see that it is a stimulant, but it is also an empathogen because it increases the amount of serotonin synaptically. So it's quite literally the love drug. It makes people feel very close to others. And it's also a hallucinogen because it does activate serotonin, certain types of serotonin 2A receptors. So it's got 3 broad actions which occur as a result of a multiplicity of mechanisms of action.
And when we're talking about MDMA, what are the typical doses that people take, and which routes or how is this drug taken commonly?
Right, so it's commonly ingested. It's commonly orally. You normally get a pill. Now, the dose of the pill, I used to say that it's about 100 milligrams. I'm not sure that's true anymore. I mean, I think that the recent experience for pill testing in Australia has demonstrated actually there is a significant variability in dosing, but 100 milligrams is the figure that sticks into my head. And actually, when you consider, if you were going to think of this as a drug, you'd have to consider the therapeutic window, wouldn't it, or the therapeutic index. So what's the difference between the dose that you want and the dose at which you get side effects? So you tend to get side effects about 120 milligrams. So it's actually quite a narrow therapeutic window. And
MDMA or ecstasy, it's quite rapidly absorbed, isn't it, Fergal? And a lot of people see effects within 30 to 45 minutes of ingestion. Could you talk to us a bit about like the time period for peak effect and the duration of MDMA post-ingestion?
So it's about 30 to 45 minutes to actually start getting any effect at all. And that's a really important point to make. You need to wait up to at least 3/4 of an hour, and I would actually say an hour, before you can make any decision as to whether or not the pill that you think is ecstasy that you've taken has actually worked. The peak effect is about an hour to an hour and a half, and then the duration of effect can be up to 5 hours. So I basically think half an hour, 1 hour, 5 hours as a kind of easy way of thinking about the clinical effect profile, which is a reflection of its absorption and then distribution and then excretion.
And you were talking a bit earlier about half-lives as well. Could you tell us for roughly that 100 to 125 milligram dose range of MDMA, what would be the half-life? And can you talk to us a bit about the metabolism of MDMA?
All right. So the half-life of any drug is the time required for the serum plasma or the plasma concentration to actually reduce by 50%, by half. And in the case of MDMA ecstasy, it's about 8 to 9 hours. So then the question then becomes, well, if the duration of action is maximum about 5 hours, how come you have a half-life that's longer? And the answer is actually, you have to understand that when you absorb a drug, concentration goes up, then it plateaus, and then it starts to go down again. But you tend not to get a clinical effect at zero. There tends to be a threshold for clinical effects. So the duration of action actually depends on the time when the rising concentration crosses the threshold and the descending concentration then recrosses that threshold for effect. So it's perfectly reasonable to have a half-life of a drug that's longer than actually the duration of effect. Mm-hmm. In terms of its kinetics, so remember, kinetics means what the body does to the drug as opposed to dynamics, which is what the drug does to the body. So we've already discussed the dynamics. We've discussed the mechanism of action of ecstasy. So the kinetics, Broadly speaking, it's very well absorbed. It's metabolized by the liver. Its main metabolic product is MDA, so methylene deoxyamphetamine, rather than methylene deoxymethamphetamine, which is what ecstasy is. And it's metabolized by the CYP system, the CYP450 system, but it's also metabolized by catechol-O-methyltransferase, which is an enzyme particularly well known to be involved in the degradation of dopamine. And in fact, we know that inhibitors of COMT are actually therapeutic interventions for Parkinson's disease. As is quite common with a large range of drugs, it's metabolized by the liver and then the byproducts are excreted by the kidneys. So if we go back to liver metabolism, there are phase 1 reactions and phase 2 reactions. Phase 1 reaction transforms a drug. Phase 2 reactions solubilize a drug. So if we look at phase 1 reactions for ecstasy, it's metabolized by CYP, it's transformed into MDA, and then it is connected by a phase 2 reaction to glucuronides and sulfates, which actually increase the solubility. Mm-hmm. And when you think about it, if we're talking about kinetics, a drug that it needs to be absorbed into the body has to be fat soluble. A drug that is then going to be excreted either into bile or into urine, both of which are basically water soluble media, that has to transform from fat soluble into water solubilities. And so that's effectively what happens in the liver. And then, of course, once it's water solubilized, it's renally excreted. And 50% of MDMA is excreted unchanged in urine. And so that really then makes it very easily detectable in a urine drug screen.
That's a great summary of the pharmacokinetics of MDMA. And I guess to kind of segue to another aspect of MDMA. Now, we're all really familiar with the stimulant effects of MDMA, the cardiovascular effects, in particular, tachycardia, hypertension, the CNS stimulant effects as well, the potential for agitation and seizures. I guess the thing that's now getting a bit more research and that is getting a bit more clinical acceptance as well as being the focus of research is the use of ecstasy or MDMA as an empathogen and the psychedelic effects. Could you expand a bit on the use of MDMA as an empathogen and its role in conditions such as treatment-resistant PTSD?
Yeah, this is a really important issue. The whole reason why ecstasy has been classified as an illicit substance is fundamentally because when that classification was done, there was no potential medical use for ecstasy, right? So there was absolutely no medical use for ecstasy. Therefore, any use was considered illicit. Now, we know that that's not true. And even as we speak now, there are multiple research centers conducting trials on the role of ecstasy, and in particular this concept of microdosing of ecstasy. They're conducting trials on the role of ecstasy in the management of refractory mental health conditions. It is really arrogant on our part to think that we as a society know how to treat with current medications the entire range of mental health disorders. And so, I think that the classification of ecstasy as an illicit substance with no medical use has basically hampered medical research for years. All right. So there is evidence emerging that it is a very useful adjunct to certainly in the treatment of treatment-resistant depression, treatment-resistant PTSD. And the key thing about ecstasy's medicinal use lies in the fact that it is an empathogen. And the key reason why it is an empathogen is, as I've already said, it inhibits reuptake of serotonin. It is a serotonin reuptake inhibitor, just like all of the SSRIs. That and various other actions then cause a downstream effect where basically it elevates the amount of oxytocin in our brain. Now, what does oxytocin do? Oxytocin is a hormone in the brain that makes us feel socially connected, makes us feel safe, makes us feel loving, makes us feel empathy, all right? It is also, if you think about it, it is the hormone that mediates the love that occurs between a mother and their newborn child, because actually oxytocin is secreted during vaginal delivery. There's a reflex that triggers oxytocin release during vaginal delivery. And that's a survival thing, isn't it? Imagine if we as a species had mums that were delivering babies and there wasn't any empathic emotional connection. Babies wouldn't survive. So oxytocin mediates that effect. So how do you demonstrate the effect of oxytocin? You talk about the love that occurs between a mother and a child. And imagine if we had all of that love when we were trying to treat people with refractory depression or refractory PTSD. That's how we have this utility for ecstasy. Now, I have to emphasize that love is not actually sexual desire, because actually oxytocin inhibits sexual desire, and it also inhibits or the ability to orgasm. So really, quite crudely, you end up wanting to hug people rather than have intercourse with them.
That's a great summary, Fergal. And I think it also shows how it's almost seemingly illogical in some instances how some drugs that we use, i.e. alcohol and tobacco, are acceptable, and other drugs which actually have clinical relevance and may be used to alleviate human suffering are illegal in certain situations. So it does, I guess, shows some of the arrogance that there is, and also the lack of uniformity in our approach to classifying drugs.
Yeah.
Regarding the side effects of MDMA, the common side effects, slight side effects that we know of are nystagmus, trismus, or clenching of the jaw, sometimes feeling hot and confused as well. But there are some serious side effects that do occur from MDMA, and I'll just list a few, but I was going to talk to you, Fergal, about them in a bit more detail. But the common ones that we get really worried about are some psychiatric presentations, in particular anxiety, paranoia, hyponatremia or low sodium, hyperthermia or high temperature, the serotonin syndrome, which we'll expand on as well, and also some organ-specific effects of MDMA, in particular the risk of liver damage. But going through these one by one, Fergal, the psychiatric side effects of ecstasy, could you expand on some of the risks that can occur with MDMA and the psychiatric comorbidity?
Yeah, so I think there's two key things I'd like to highlight. Firstly, it is a hallucinogen, so you can really get a frank psychotic illness as a result of it. You can hallucinate. And that's because it is a serotonin 2A receptor agonist. And actually, a lot of the antipsychotic actions of the atypical antipsychotics that we have are actually serotonin 2A antagonists. So there we have an example of agonism and antagonism working firstly to create psychosis and then to treat psychosis. The second one that I really want to bring into the forefront is this risk of hyponatremia. Now, hyponatremia, as a result of ecstasy intoxication, is particularly a problem for young women. For some reason, women tend to be more sensitive to the effect of ecstasy causing hyponatremia. Why is that a risk? Well, it's a risk because you can die from one pill. There have been in various countries, various newspaper reports, sadly, of deaths due to one pill ingestion of ecstasy. And more often than not, they have occurred as a result of acute hyponatremia. So what is hyponatremia and why does it happen in ecstasy toxicity? Well, it happens as a result of the syndrome of inappropriate ADH, which basically means we retain water and we dilute our salt. And then when we dilute our salt and we retain water, what happens to the brain is that it basically swells up. And so some of that dilute fluid from the plasma then enters into the brain tissue, causing brain swelling. And as you know, swelling of the brain inside a tight space of the skull is not good for anyone. And ultimately it can cause seizures, it can cause herniation and loss of consciousness, coma and death. And this has actually happened. So it's really, and actually it's not just a problem with ecstasy. This can also happen with amphetamine or methamphetamine use disorder. but it's more common with ecstasy. Now, the key thing to understand about this is that people think that when you're taking stimulants or ecstasy, you have to drink a lot of water. Actually, drinking too much water is an issue with this. So I often say, if you're dancing, no more than a pint an hour, which is about half a litre. And if you're not dancing, no more than half a pint, which is about a quarter of a litre an hour.
The other side effect that you often hear about is hypothermia, and that can be due to the drug itself or due to MDMA itself, but it can also be secondary to like a serotonin syndrome, as we talked about a bit earlier. What's your view on the hypothermic risk of MDMA, Fergal?
Well, I mean, think about the context. So you're in you take ecstasy at a rave, you're in a hot, sweaty nightclub, it's full of people who are all irradiating heat. You take ecstasy, you end up with a high temperature reaction. You don't actually sweat enough. You're surrounded by hot people. You become dehydrated. It's also a risk factor then for melting of the muscles, which is rhabdomyolysis, as you've already alluded to. And again, that too can cause problems. So there are problems both with overhydration and dehydration when you're using ecstasy. And it's really important to get that absolute balance right. And
I guess lastly, we've already kind of touched on the serotonin syndrome earlier in the episode, where we've already explained that MDMA acts to inhibit serotonin reuptake inhibition, causing serotonin dumping, leading to excess serotonin in those synaptic clefts, and that can cause increased delirium, hypertension, tachycardia. It can cause hyperthermia, and it can, in significant cases, be fatal. So serotonin syndrome is something to be aware of. But I guess lastly, and to finish off this episode, Fergal, I think we should also talk about the organ effects of MDMA, and in particular the cardiac effects, as well as the effects of MDMA on the brain and liver. What are the main takeaways our listeners and viewers should be aware of with regards to MDMA and some of its end organ effects?
So again, it's really important to understand that ecstasy is not a safe drug. It's as potentially as dangerous as the stimulants, and it's really important to understand that ecstasy and the stimulants don't just have effects on the brain. They don't just get you high. They also can actually impair your physical health. So in the heart, we know that it causes reuptake inhibition of the monoamines surrounding the heart. So basically, it's overstimulating the heart. And it can then cause vasospasm, so it can shut down the artery supplying the heart. It can cause problems with blood supply to the heart. And it can cause angina, or can cause even heart attacks. So when I hear of stories on the news of young Hollywood starlets who at 4:00 in the morning are being rushed off to a hospital in Los Angeles with a heart attack, well, young fit adults tend not to get heart attacks. So I often feel that the reason why that this is happening is because they've taken a stimulant, either amphetamine or methamphetamine or even ecstasy, and it's caused them to undergo a vasospastic attack. There are other mechanisms by which ecstasy can damage the heart, and so it basically, the effects that you've already described, the hyperthermia, the high temperature, and also the serotonin, this can also cause downstream heart damage, including ultimately cardiac arrest and death. Mm-hmm. So it's got a wide pathophysiology in the heart. Talk us through, Philippe, if you would, the brain.
So MDMA and its effects on the brain are multiple. We've talked about surges in blood pressure associated with MDMA usage, and that can certainly increase the risk of rupture of pre-existing aneurysms or arteriovenous malformations, which are collections of abnormal blood vessels. It can increase the risk of intracranial hemorrhage or bleeding in the brain as well. And also, as with any hallucinogen, it can also increase the risk of developing a delirium, which in untreated cases or severe cases can be fatal, especially in those who are already vulnerable due to other health conditions as well. So it can cause some pretty significant cognitive and brain effects as well. And I guess, Fergal, to wrap up some of these end organ things, MDMA's effects on the liver are particularly well known. Could you talk us through some of the liver effects of MDMA?
So you can get a direct hepatotoxicity, so it can cause direct liver damage, like practically any drug can theoretically cause liver damage. But also you have to accept the fact or appreciate the fact that liver damage can occur also as a result of the hyperthermia and the high body temperatures that can occur as a result of serotonin syndrome, which is again a downstream effect of ecstasy toxicity.
So it's been a pretty information-packed episode of Cracking Addiction today. We've talked about MDMA, we've talked about its pharmacokinetics, its pharmacodynamics, both the recreational use of MDMA as well as some of the therapeutic options and interventions that are being explored currently. And we've also talked about the interactions of MDMA, both with different chemicals within the body, but also its effects on end organs. So it's been, again, another action-packed episode of Cracking Addiction. Thanks for your attention, and bye for now.